Hello, greetings everyone here, and greetings to the Zoom participants who have joined for this journal club meeting. Just a brief introduction. I am a fourth year pathology resident, Dr. Mohammed Ahsan at Chuktai Institute of Pathology, and currently I'm also serving as one of the digital ambassadors for the Cancer Cytopathology Journal, and I've completed my online digital pathology communications fellowship also. So today's topic for the journal club meeting is what's new in salivary gland cytology. So we'll be discussing the Milan system for reporting the salivary gland cytology. So what was new and big last year? Since we are also thinking about a movie night, so what movies come to your mind in the last years? So the big three was Oppenheimer, Barbie, and Guardians of the Galaxy. But what was new in the world of cytopathology? So it was the Milan system. Second edition of the Milan system was published last year. And the editors of the Milan system are Dr. Diana Rossi, Dr. William Fraquin, Dr. Zubair Baloch, and Dr. Felipe and Dr. Barkhan. So while I was making this presentation, I was thinking, like if any of the authors are actually from Milan. So none of the editors and the authors are from Milan. Only Dr. Diana Rossi, she is from Rome, and Dr. Faquin, he is from US. Dr. Zubair Baloch, he is from Pennsylvania. Dr. Felipe, he is from France. So none of the authors is from Milan system, from the Milan itself. So the review article that we'll be discussing today is all the authors of this articles are also the editors of the Milan system itself. So the article is the second edition of the Milan system for reporting the salivary gland cytology, refining the role of salivary gland FNAC. And this was published in January 2024 in Cancer Cytopathology, which is the official journal of the American Cancer Society. So just an overview. So what are the things that have been updated in the Milan 2.0? So the risk of malignancies are revised in each category. So there are 6 diagnostic categories which we'll discuss, and the risk of malignancies has been revised. There have been a new chapter on imaging. There's no new chapter on ancillary studies, and the WHO entities and nomenclature has been used. So how many of you know that there is a website of Milan system, and you can access it from this link, or you can even scan this QR code from your mobile phones and access the website of the Milan system. So they also have like the example or the case studies for each diagnostic categories, which you can review. And by the way, they also have their Twitter account if you want to check it out. So here is the index of the second edition of the Milan system. So there is a chapter for each of the diagnostic categories, and there's a new chapter on imaging that is added in the second edition. So some facts about the salivary gland. So first of all, we should all be aware of the normal locations of the salivary gland. So the largest salivary gland is parotid, and it has this location. And we should also be aware of like the tail of the parotid is at the angle of jaw. So sometimes we receive an FNAC with the clinical history, like there's a neck swelling or a lymph node, and it turns out to be salivary gland FNAC. So the tail of the salivary gland is at the angle of mouth, and here at the cheek, in some individuals, accessory parotid can also be present. So this should also be kept in mind. So the incidence of salivary gland tumors at is like uncommon 0.4 to 1.4, 13.5% per 100,000 people, usually in adults, and the parotid gland is the most common location. And most of these salivary gland tumors are benign, and the general rule is like the size of this salivary gland. If the larger the size, more likely it's gonna be benign. So most of the parotid tumors are benign, and most of the smaller salivary gland, the incidence of the malignant tumors are high there. So 20% is the risk of malignancy in parotid, and it's increased to 80 to 89% in the oral cavity. So the diagnostic categories in the second edition remains the same as they were in the first edition. So they have these 6 categories. The category 1 is non-diagnostic. Category 2 is non-neoplastic. Category 3 is atypia of undetermined significance, or AUS. And then 4A and 4B is reserved for the benign. For the neoplasm, benign neoplasm is 4A, and salivary gland neoplasm of undetermined malignant potential or SUMP is 4B. Suspicious for malignancy is 5, and malignant is 6. So this is the beauty of the Milan system, that it doesn't have the 2 categories like benign and malignant. It has a range of diagnostic categories from non-diagnostic to all the way to the malignant, because in human body and biology, not everything is black and white. So the cases that we see in everyday routine, we have like some of the cases, they're non-diagnostic, some they are like suspicious. So we have these range of diagnostic categories. So here is the comparison of the Milan system first edition and the second edition, which was published in July 2023. So the major difference is in benign, benign category and malignant category. So in the first edition, the risk of malignancy was like approximately 5% or less in for the benign category. Yeah. But now in the second edition, the risk of malignancy is reduced to less than 3%. In the first edition, the risk of malignancy for the malignant category was around 90%. But in the second edition, the risk of malignancy for the category 6 or malignant is 98%. So these are the 2 major changes. There are minor changes in other categories too, like non-diagnostic. The risk of malignancy was 25%. Now it is 15%. In non-neoplastic, it was 10%, just a minor change to 11%. AUS was 20%. Now it's 30%. So benign is now less than 3%. And SUMP was like 35% in the first edition, and it remains the same in the second edition. Suspicious was for malignancy was 60% risk of malignancy. Now it's increased to 83%. And for the malignant category, it is greater than 98%. So these are the diagnostic categories, and these diagnostic categories are actually based on the clinical management or the patient care. So if it is non-diagnostic, then the management will be like repeat FNAC or correlation with the clinical or the radiological findings. If it is non-neoplastic, then clinical follow-up and radiological correlation. If it AUS, then surgery or repeat FNAC are the options. And for neoplasm, like some suspicious for malignancy and malignant, the surgery is the treatment of choice. So now discuss each of the diagnostic categories of the Milan system with some case and examples. For the non-diagnostic, what we usually consider as like if we have blood and hemorrhage only, or if the cellular elements are too scant that we cannot reach to any of the diagnosis. So in example A, there is a hypocellular FNAC, mainly red blood cells and just a few epithelial cells. In example B, there is fixation-related artifacts. So we classify it as non-diagnostic. For non-neoplastic, the examples are sialadenitis. For example, in example A, there is granulomatous sialadenitis, and in example B, there is chronic inflammation, so chronic sialadenitis. And some of the infection, like fungal infections and other infections, also fall in this non-neoplastic category. For AUS, if we have, as in this example, we have acellular mucin, so low-grade mucoepidermoid carcinoma cannot be ruled out. So we sign out these sort of cases as AUS. So there is a case study. So we have this FNAC and a cell block from a 83-year-old female with a history of breast cancer. And what we see on the cell block are like oncocytoid epithelial cells with abundant cytoplasm, and at the periphery, there is lymphoid tissue. So what would be the potential differential diagnosis in your mind for this case? Could it be Warden? Potentially, yes. Or some oncocytoid neoplasm. And like even some malignant neoplasm, they have some oncocytoid variants. So for this case, like the differential diagnosis includes benign and some of the malignant neoplasms. So here is the example or the algorithm for such cases. So if we have this on cytology, we have an oncocytoid or oncocytic neoplasm. So the differential diagnosis would include if we have like inflammatory cells or cystic background. So the differential diagnosis would be like Warden and sclerosing polycystic adenoma, cystadenoma, actinic cell carcinoma, and even oncocytoid variant of the mucoepidermoid. And if we have some granular or vacuolated cytoplasm, then this secretory carcinoma and actinic cell carcinoma, some of the cases can have these oncocytoid cells too. So what do we do in these sort of cases? So if we only rely on cytology in the cell block, then there is like potential overlap from the benign and even from the malignant category. So all the even the Warden is in the differentials, actinic cell, secretory carcinoma, and even mucoepidermoid carcinoma oncocytic variant is in the differentials. So either we can put it in the salivary gland neoplasm of undetermined significance or sum, or we can choose to make a cell block and perform specific IHC. So in this case, if we apply IHC, so the diagnostic category of the Milan system, it would alter, and the patient management would differ. So one of the most commonly asked question is, when do we consider IHC and then ancillary testing for the cytology specimens? So if there is diagnostic uncertainty, and if by the application of IHC, we can reach to the definitive diagnosis, and it can potentially, if it can alter the categories of the Milan system from benign to malignant or benign to suspicious for malignancy, then it's worth doing the ancillary studies, and it would definitively improve the risk stratification and the risk of malignancy and help guide the clinical management. So here is an article about an algorithm about when to apply IHC stains for a cytology specimen. So the first question you ask to yourself, is it a neoplasm or not? If it's not a neoplasm, then there's no need to apply immunohistochemistry. And if you are unsure, like if it's AUS, then the only reason to apply IHC is if it potentially alters the diagnostic category of the Milan system. And if you're sure that it's neoplasm, then two possibilities are like if it could be like benign or malignant. So the next question you ask yourself is the morphology diagnostic for a specific entity? And if it is diagnostic for the specific entity, then you reach your diagnosis, either a benign neoplasm or a malignant neoplasm, then there's no need to apply the further IHC or ancillary testing. But if it is not diagnostic of a specific entity, then it could be like benign neoplasm, malignant neoplasm, some or suspicious for malignancy. So the next question you ask yourself is, would a specific diagnosis alter the category of the Milan system or not? And if the diagnostic category of the Milan system is altered, then we apply ancillary testing. And if it doesn't change the diagnostic category, then it is optional to apply IHC staining. So if we are considering SUMP as our potential diagnostic category on the cytology and the cell block, then as in our case, the cytology was oncocytic or oncocytoid neoplasm. So the differential diagnosis to consider were like Warden, oncocytic mucoepidermoid, myoepithelioma or carcinoma, adenoid cystic or secretory carcinoma. So then we apply the relevant IHC panel to reach the definitive diagnosis. Now, let's get back to our case study. So it was oncocytic or oncocytoid neoplasm, oncocytic epithelial cells with the lymphoid background. And the IHC stains were positive for mammoglobin S100 and CK7 SOX10 and GETA3 were also positive. Pancreas was positive and negative IHC were P50, P63, DOC1 and AR. So what is your diagnosis now? Yeah, secretory carcinoma. So the final diagnosis is Milan category 6, malignant, and the diagnosis is secretory carcinoma, low grade. And this was the follow-up resection of the same patient, and it was signed out as secretory carcinoma with prominent tumor associated lymphoid proliferation, and the lymphoid background, it mimics Warden tumor or a lymph node. So what's the take-home message from this case? So by applying the specific IHC staining, so the diagnostic category of the Milan system was changed. If we sign out this case as SUMP, then the risk of malignancy would have been 35%. If we sign out this case as suspicious for malignancy, then the risk was like 83%. And if we consider even like Warden in our differential, then the risk of malignancy would be like less than 3%. But if we apply specific IHC and sign it as malignant, as category 6, then the risk of malignancy is greater than 99%. So we have to apply IHC and prepare cell block for the cases which can potentially change the diagnostic category. Now let's talk about the malignant category of the Milan system. So there are no significant changes in the second edition, just the risk of malignancy is increased from 90 to like 98 or greater than 99%. And for this category is reserved for the cases in which the diagnosis of malignant uh, tumor can be made on cytomorphology alone or with the help of IHC testing. And we should also provide the grade of the tumor and other malignancies. They should be specified. For example, lymphoma, metastasis, and sarcoma, they also fall in this malignant category. And in the second edition of the Milan system, there is a new chapter on ancillary testing and also FISH and NGS and the genetic alterations. We will briefly talk about it also. So here are some of the genetic alterations that are common in some of the salivary gland tumors. For example, in pleomorphic adenoma, there is PLAG1 and HMGA2 rearrangements, and so on. Here is the long list of IHC of the genetic alterations that are prevalent in the salivary gland tumors. Microsecretory adenoma is the new genetic alteration that has been added in the second edition, and it has this MEFC SS18 fusion. And there are few mutation and fusions against which a specific and a targeted therapy is available. For example, RET is receptor tyrosine kinase, so we have like and medications or treatment against the tyrosine kinase receptors. So it is altered in intercalated duct subtype of basal cell adenocarcinoma. And we have HER2 amplification and androgen receptor mutations in salivary duct carcinoma. So here is an overview. Like in salivary duct carcinoma, there is AR and HER2 against which specific targeted therapy is available. In secretory carcinoma, we have S100 and mammoglobin. In actinic cell carcinoma, we have TOC1 IHC. And for these genetic alteration, the surrogate IHC markers are also now available for pleomorphic adenoma. IHC for PLAG1 is now available, and HMGA2 IHC is also available. MYB IHC is also available for adenoid cystic carcinoma, and for actinic cell carcinoma, we have NR4A3 IHC. So these IHC markers can be used as well. So here is another article, like we can use these IHC markers instead of calling specimen and putting it in the sump category. So don't sump it. So this is the utility of PLAG1 IHC in basaloid subcategory. So in this case, we have like on cytomorphology, the features are of pleomorphic adenoma with hyaline globules, and the IHC was positive for PLAG1. So the two differential diagnoses to consider are pleomorphic adenoma, and some subset of basal cell carcinoma are also positive for PLAG1. So if we like keep both in our mind, the cytomorphology and the IHC stain, If it looks benign, then we can easily sign out these sort of cases as pleomorphic adenoma instead of calling it SUM. So we'll briefly talk about the role of NGS. It is not routinely used for the cytology specimen, but like one of the benefit for this is like a single test can be used to detect like more than 1,000 potential genetic alterations. So one such test is salivary gland DX. It is a comprehensive panel. So a single test can detect all these genetic alterations. So we can be like get to a definitive diagnosis with the single test. Then the use of fluorescent in situ hybridization of FISH is also useful, but like this is usually used in combination with the FISH and the IHC. They are usually uh, like used in combination, and a combination can be like 100% specific and a sensitivity with a sensitivity of 66%. So take home messages for this presentation. So there is clinical role for salivary gland FNA to guide the management, because this diagnostic categories, they are based on the management of the patient. And Milan system provides a standard means for reporting FNAC. So there is a uniform system for reporting the salivary gland cytology all over the world. And ancillary testing can help improve, and it can improve the diagnostic accuracy of the FNAC. So the main success of the Milan system would be actually when the clinicians or the ENT surgeons, they're starting using the Milan system. The pathologists, they are also, and they are already using it all over the world. But the real success of the Milan system would be like if the surgeons start using it. So one way for this is like if we educate the surgeons, and one other thing is like pathologists usually publish their findings and their articles in the pathology related journals. If they also consider publishing in the ENT or the surgery related journals, then the surgeons, they will get used to the Milan system. So that would be the real success of the Milan system. So this was an article, a call for universal acceptance for the Milan system for reporting salivary gland cytology. And that's all. And these are all the editors of the Milan system. And as one of the ambassadors for the cancer cytopathology, I have the pleasure to work along with the editors. Dr. William Fossen, he is also editor-in-chief for this cancer cytopathology. So I'm working along with Dr. William Quackwin as ambassador. And in one of the meetings for the cancer cytopathology, I had pleasure to meet and connect with all the editors, including Dr. Zubair Baloch, Dr. Felipe, Dr. Diana Rossi. Thank you. Any questions, comments?